Okay, thank you very much, everyone, for coming. No disclosures on this. Lots of different complications, and the more different things we treat, the more complications we're going to see. And, you know, it's certainly in the United States, there's this whole, everyone seems to be injecting some sort of a neurotoxin now. Your pediatricians, your OBGYNs, med spas, and I think they're sold this bill of goods that it's very easy. But there are just a lot of different complications, and so we're seeing more and more complications because people who don't really know the anatomy are injecting. And when people come in like this, you better know what you're doing, or you're really going to make them even worse. The other thing is, you know, under correction. I think when we first started, there were a lot of people who wanted total paralysis, and especially we used to see that in the forehead. And but we don't really like to do that anymore because it really makes a mask-like face. And let me just see if I can get to this picture here. When we used to do the forehead, starting out in the forehead, I would put an awful lot up there. But what happens is that it doesn't move at all. So as light reflects off of the forehead, you get this shiny brow, and people used to refer to it as a Botox brow. So I think now we really want to keep a little bit of movement in most people. You still have that rare person who wants total paralysis, but I think for most of us, that's not the way we're treating anymore. Bruising, not really a complication, but patients perceive it as a complication. And so if they're on anticoagulants, tell them they might bruise, or some megavitamins. If there's someone who bruises all the time, you can use some ice. And if you do a subcutaneous injection instead of right into the muscle and use a small needle, you actually can decrease the incidence of bruising. Immediate pressure if you do see any bruising. And there have been studies showing that subcutaneous injections actually work just as well, and what you do is you just inject subcutaneously, especially in the crow's feet area. You just then put a little pressure on, you'll push it down into the muscle, and it's also less painful for the patient, so they really will like that. A lot of complications are usually from diffusion into the surrounding muscles, and intradermal injection may decrease the diffusion. Some people complain of a headache. I think that's when you do a glabellar injection. They just get a little bit of maybe edema or inflammation from the needle itself. And so if you use a smaller needle and the preserved saline, usually they do not have that problem. Dry skin, you can definitely see some flakiness. People don't usually even notice it or complain about it, but it's probably just due to decreased sweat gland activity like you would use for hyperhidrosis. And certainly up here you have a lot of sweat glands in the glabella, and some people will see some dryness. Ptosis. This is one of the most, the complications that people really do not want to see. And it can be seen anywhere from 48 to 48 hours to 1 week after the injection. And it can last for a few weeks. And the levator muscle, which is responsible for elevating your lid, is very susceptible to even a small amount of Botox. It has a limited number of motor end plates, so you have to be really careful here. And it can be from injection into the orbicularis, the corrugator, the procerus, and possibly even into the outer brow. In some cases, when you do some brow injections, you'll actually see a lid ptosis that before you didn't notice because they were using their frontalis. And Dr. Julie Woodward, who is here, they showed that probably when people do get a ptosis, it's from tracking down from the forehead through the tributaries of the superior ophthalmic vein, and they did a nice study showing that. So that's probably where you're going to see the ptosis. When you do see that, you can treat it with one of the alpha-adrenergic stimulators, which will stimulate Mueller's muscle, which is on the inside of the lid, the other elevator. And aproclonidine or iopidine, which was used for glaucoma, is sort of the best drop for this. And you can use it twice a day. This is a patient that came in with ptosis, and here she is 3 months later. And it's interesting, when you get the ptosis, the other side will actually lift even more from something called Hering's Law. Once you lift even with the iopidine, that one will drop a little bit. Frontalis injections, just remember that your brow will be lowered and then asymmetry can be exaggerated. So this is what I call the danger area in here, because if you go too low, you can definitely drop a brow. So if someone has a low brow to start, you can actually make that significantly worse. If you do see someone with a low brow and they still want injections there, you have to stay fairly high and just tell them you're not going to get rid of all those lines. The lower lines are going to stay. And here's a patient who had an injection, and it's interesting to see the extra skin here, because as the brow fell, all of a sudden she couldn't lift that brow and keep that skin off of her eyelid. So you can see this side is higher because the frontalis is still working here. This side it's not working, and it actually will show the dermatochalasis or ptosis if they have a true ptosis. Lateral eyebrow arch, what we call the Spock look, and if that happens, it's pretty easy to fix. You can just go up above, This is one of my favorite pictures. This is someone who sent me an emergency selfie as she drives in Miami.
Emergency selfie.
And, you know, you see it all the time there, but I was like, are you kidding me? And so anyway, if you come in, you just put a little bit of Botox up in here, a neurotoxin, and it'll drop that brow. Here's another case. The lateral frontalis is still working, and so they have these lines over here. But you have to warn them, if you want to get rid of these, it'll drop the brow. And so, but if it's too high, you really want to do that. You don't want them to walk around with that super arched brow. Recruitment, when you do the glabella, sometimes what will happen is the corrugator, especially, goes all the way along the upper part of your brow. And if you immobilize the medial part, sometimes your brain is trying so hard to get that muscle working, it'll start to recruit a little bit. So here we put some here, because she didn't really have much over there. Then this is a little more relaxed, but all of a sudden these lines are starting to show because she's desperately trying to use that muscle. So then I had to come over a little bit here and actually just go further laterally with her injections. This is another thing where you can get in trouble. When people have these really long lines, if you start treating way over here, you're going to throw off their smile. And they really won't like that, so you have to explain to them. You can help with the crow's feet, but when they have these really long lines that go all the way out here, once you start treating down here, you're definitely going to affect their smile, and they're going to be very unhappy for 3 months, and you can't fix that. So you just have to explain to them, you can't get rid of all your lines. Another thing is realistic expectations. If someone has a really deep line, and they've been working on that when she frowns, 2 weeks later, they're still going to have a line, and you have to tell them, if you have a deep line, it's not going away with one injection. Maybe after 2 years, I say, of injections every 3 months, you can get rid of that line, but you're not going to get rid of it with one injection. You can also offer them some filler. Definitely it's a high-risk area for filler, so just be very careful if you do that. Lack of thalamus can occur if you do into the supratemporal orbicularis. Ectropion could occur, it doesn't happen very often, and it's just elderly people with very lax lids, be very careful. Dry eye, very uncommon, but it could happen. Strabismus would usually be from a lower lid injection, and I saw this in one patient where giving it into the lower lid, into a hypertrophic orbicularis, some of it must have diffused into the inferior oblique muscle, so that when she looked up and out, she had double vision. So be very careful. Just give a little bit, give it superficially when you do a hypertrophic orbicularis. Pseudoherniation of orbital fat has been reported from decreased orbicularis tone. Upper lip weakness, they were talking about that, go very, very small amounts into the upper lip. You can't pucker and whistle, and especially if you give a lot, you can't use straws, and I've had people say that it changes their speech patterns, especially Michael New Yorkers who tend to purse their lips when they make their bow in New York, and all of a sudden they'll say that they sound different, they lost their accent, which I don't think they have, but it's interesting how they feel like they're speaking differently. So limit your lip injections. Same with mentalis injections. Tatiana was talking about that. You can get lower lid droop and weakness. And the DAO also, be very careful here. If you go to medial, you can get the depressor labii muscles, and you'll see no lower teeth with a smile. Luckily, this woman's a good friend of mine, and this is what she came in looking like. So some of the injection from her DAO came over to the depressor inferior here. So what we had to do is give a little bit there, and then you get so that she will be symmetric. What she didn't like was that then her teeth don't show when she smiles, so she never wanted to do it again because she has this big smile, and she didn't want to lose that. Here's another one from doing over in the mentalis, or rather the masseter for TMJ, and what happened was that some of it came over into the DAO, so all of a sudden she couldn't pull the corner of the lip down on this side, and so this is her, again, in 3 months, it all came back. So be careful down in this area. If you go too medially, you won't be able to lower your lip. Platysmal bands, usually you can often use very large doses here, but you can get temporary dysphagia and hoarseness, and some people will get neck weakness, and there have been patients who have been reported that they can't swallow, so you have to be very, very careful. Start with small doses there. Do not over-inject because you can get some significant complications. And this was a woman who had some injected, and after a while she couldn't hold her head up, and then she ended up getting a feeding tube, and then she ended up dying from this. So this was a major lawsuit, so be very careful there. Also, make sure you use legal Botox. Make sure you use a legal neurotoxin. I use Botox for all of them. There was a doctor in Palm Beach who ordered some. It was a discounted version, and what he ended up actually ordering was 20,000 units. and he thought it was 100 units in the bottle. So he diluted it with 10 cc's of saline, injected himself, his girlfriend, and 2 other friends, and they were all on respirators for 6 months. So, you know, a lot of people are trying to save $1 by buying these neurotoxins from around the world, but really be careful because you do not know what's in that bottle unless you get the right thing. Resistance, not really a complication, but certainly patients aren't happy about it, and it's when you can form antibodies because there's definitely a foreign substance being injected. And only antibodies which are against the active portion of the molecule will cause resistance. And so there are 2 types, neutralizing and non-neutralizing. With the early Botox that actually had a lot of protein, they thought it was possibly from that, and they changed the way that they made it so that there have been fewer cases, and it's usually for people who have received high doses. I actually am one of the people who has total resistance to botulinum type A. I have done it for about 4 years, normal doses, developed resistance. Then I tried B, I used that 3 times, developed resistance to that, so they actually do my blood, send it to a special lab to look at my antibodies, because what they're trying to do is get a good vaccine for people who are in the armed services, so if there's ever chemical warfare, they would also have resistance. But so for me, I'm just waiting for CD&E to come out so that I can have something to use for my growth feed. Risk factors for resistance would be the high doses, short intervals between injections, and just people's different immune systems. And when they did a meta-analysis, they found that 11 out of 2,240 were positive for antibodies, but 7 of those 11 still responded. And death, you need 2,800 units for a 70-kilogram person. So if you're using a 100-unit bottle, it's pretty rare that you would see any real problems with the health of a person. No reported deaths from aesthetic Botox. So minimized by good injection technique, good understanding of facial anatomy, appropriate site-specific dosing, and usually your complications are short-lived, or most things you can actually fix by putting a little bit of neurotoxin in another area.